we know that every anatomy is different, so we want to simulate the anatomy, make sure we cover the entire anatomy. The most common problem with bifurcation is we will have something like this, and we will have an angle like that, and when we stent, we will either have a geographical miss here, or we might over protrude the stent and cause extra strut outside. So I think that is a real challenge. So we need to have no geographical miss, strut apposition in the entire bifurcation, mimicking a normal anatomy, a native anatomy, and we need to have very good expansion and apposition in the entire main branch and the side branch. That is what is the objective. So what do we know about kissing balloon inflation? I think, as you all agreed initially, I think in provisional, it may not be important for everyone, but I think with large bifurcations it may be important, particularly because we will have good access to the side branch, as well as the importance of clearing the struts across the ostium. I think we're going to talk a lot about this, and the importance of side branch scaffolding, by which I mean with a single stent, we can also cover the ostium of the side branch by doing a good kissing balloon. So we know that it is mandatory in double stenting techniques, but in provisional, I think we need to give importance to large branches. But what are the potential downsides of routine kiss? We know that this is associated with more complexity, longer the procedure. Not only that, there are reports of oval distortion of the main branch, distal main branch, when we place two kissing balloons and simultaneously dilate. So what have we learned from bench testing? So far, we know that when we have a main branch, if you have to, so what happens is if you want to dilate through a main branch stent, invariably you will distort the stent. So if you are going to dilate a stent on the side branch with a balloon, you will have a distortion, and what happens is the main branch stent, as you can see, goes up. Can you move next slide, please? So you can see the video where we have put a balloon, we have stented the main branch. We're going by dilating the side branch with the balloon, and so we're dilating a main branch with the balloon, and we could see that there is a distortion which is caused by the balloon, and there is you can see at this point, we can see some distortion, and this is very important to know, because once you put a balloon into the side branch, we have to kiss, otherwise you're going to cause distortion of the stent. So as long as a provisional stent, if you don't disturb the side, if you don't put a balloon into the side branch, then we can even go without kissing. So I think it's also important that to know that the importance of pot and distal cross. I think that is very important if you are going to do a kissing balloon. I'll come to that in the next slide. Next, please. Okay. So what do the data tell us? Again, I think we all know that routine kissing is not going to be beneficial. Multiple number of trials. Also, if you look at some amount of meta-analysis has clearly shown that there is no benefit with routine kissing, but there are reports that some of the patients who can develop even benefits in terms of reduction in side branch ostium restenosis with kissing balloon. But there were some conflicting reports which said that in some of the patients, after kissing balloon, they develop restenosis in the main branch distally, particularly because of overdilatation caused by the kissing balloon. So with all this, there is clear controversy, and there is no definite clear data in telling that kissing balloon is better than no kissing balloon. But this is particularly with relevance to the provisional stent technique. But when double stent techniques, we definitely know that kissing balloon is very important when we do double stenting technique. So what does autopsy studies tell us? Again, this is a very interesting study. I took it from Renu Gurmani's center, where they found that, very important, they found that by all left main patients who died due to left main stent failure, they found that, if you look at the conclusion, our data demonstrate that the main pathological predictors for left main stent failure are malapposition and struts crossing an ostial side branch. And that suggests that imaging guided PCI may be important. So this is again a very important information, and you can see there in their study, one of the most important factors, risk factors, are malapposition, and if you look at it here, struts across the circumflex, where they could see there is a lot of thrombus in the patients who died. That's again an important information from this autopsy study. So what do? Should we do a routine kiss? So as of now, I think we don't have enough data to recommend kissing for all bifurcations, but there is no penalty by doing a kissing balloon routinely. In case if needed, we can always have access to future interventions to that vessel. So routinely we should not kiss, but any large branch such as left main, I think as you all initially said, I think we should do a kissing balloon. So another interesting observation from, this is actually from Ronnie Matthew, who presented this in European Bifurcation Club meeting in 2019. So this was a follow-up of a patient who had a crossover stenting from left main to LAD, and this show after 1 year, 2 years follow-up, he found that there was some, the circumflex ostium, he found some irregularities, and then in the OCT, OCT showed there was a tissue bridges or growth across the struts of the stent. The first time when he did the PCI, there were a lot of struts which was lying over the ostium, there was no kissing balloon done, and the struts were left alone. And after 2 years of follow-up, you could see the tissue bridges coming up, and you could see that the fenestrations which are seen. So ideally, now that we know that leaving a struts to the ostium may not be good, how do we achieve that? It's also important to have a distal rewiring. That's very important if you want to achieve a good kissing balloon. So if you can see in this image, this is a mid-cross or a proximal cross. We will leave a lot of struts still on the distal part of the carina. So it is always important to do a good pot so that we expose the distal part of the strut nicely and then cross distally and then do a kissing balloon, which will give a good scaffolding and leave no struts in the ostium. So this is one of the bench studies where you can see that if you cross very distally, you can get a good scaffolding of the side branch ostium as opposed to the proximal stent where you can have a lot of protrusion of the strut into the main vessel. So we can do either by fluoro, I think we all use this fluoro, use a jailed wire as a marker and go distally, or even sometimes use a stent boost as a help, but particularly 3D OCT is now very important and useful, and this is a Japanese study where they have shown that when you use OCT to guide the wire recross, we can achieve up to more than 84% as opposed to 67% only by angio-guided rewiring into the distal strut. So what they have found is, in OCT studies, 3D OCT, as well as OFDI studies, where they had a carpet view. OFDI is from Thermo, where they had a carpet view, which is expansion of the bifurcation, where you can see the strut pattern. And they have described two typical patterns, which is link-free type and link-connecting type. By which I mean, if there is a link connector, which is seen within the side branch ostium, then it's called link-connecting type. When there is no link connector, then we call it as link-free type. This is important because if you have a link-free type and you cross distally, you're going to clearly remove all the struts away from the side branch. Whereas in link-connecting type, sometimes even if you use a kissing balloon, you may not be able to push away all the struts. So as you can see in the upper image, you have a distal cross and you've achieved a good, after kissing balloon, we achieved a good lumen. Whereas distally, this is again, it's a link connecting type, and we can see that even with the kissing balloon, still a lot of struts are protruding into the ostium. So this is a consensus of a European Bifurcation Club, a Japanese Bifurcation Club. So depending upon the stent configuration, you can see in the upper part of the image, you can see the different stent types depending on the stent type. If you look at the upper part, we try to cross as distally as possible. We want to cross somewhere distally, and if that is not possible, take the next distal strut as you can in the configuration 2. In the configuration 3, you can see there are two cells, and you can see this, the distalmost cell is very small. So you take the next bigger cell, which is large, compared to the one on the right, the left cell is a little large, so you choose that cell. Similarly, for different types of stent, Zynes has got a peak to valley design, and you can choose the most distal strut or the next bigger one. If the distal strut is very close to the rim of the side branch, you may not be able to go to the distalmost strut. Again, in this study, they have shown the most important predictor of the side branch, ostial side branch issues are related to link connecting type, which I discussed, as well as the distal cross. So it's important to know by 3D whether it's a link-free type or a link-connecting type, or if there is no jailing at all, then we can probably leave it like that. In some of the cases where it is not possible to push away the strut despite kissing balloon, they have described a technique called push balloon technique, where an anchor balloon is placed in the LAD and a small balloon which is inflated in the left main and pushed across into the circumflex, which has been shown to clear away the struts, and then followed by a kissing balloon where we get a good clearance of the struts. So it's very important to have a good pot. Unless you have a good pot, that is because it's so important to make sure the distal part of the struts are open. If you don't have a good strut, then you will ultimately keep wiring into the proximal strut. So if you have a good pot, you're going to expand the struts completely and allow wiring into the distal strut. Once you wire into the distal strut, you will achieve much better opening of the side branch. So that's important, and I think I don't have to emphasize much on the importance of positioning of the pot balloon exactly at the level of the carina to achieve good results. Otherwise, it will distort the carina. You can also use stent boost and imaging. I think the other important thing is to remember that short overlap with kissing balloon is important. And recently, there was a study published about a few months back on using ultra thin struts with kissing balloon, which showed promising results with kissing balloon. There's only all studies which showed promising results with kissing balloon, but the technique what they used was a very short overlap, thereby without causing any distortion to the. So if you can look at the image on the left, this is an image done with the long balloons, and you can see the OCT image distally where the stent is distorted, and you can see over dilatation at the distal part of the main branch just before the side branch. So to summarize, 3D OCT is very useful, particularly to guide, to understand the struts across the side branch ostium, to understand and to cross in the distal strut in the provisional stenting, so that we get optimal. So to conclude, no evidence for routine kissing balloon for all, but kissing balloon is obviously needed in large bifurcations, but it's very important to have very meticulous attention to pot, because that is going to open up the distal struts, and we are able to wire distally and then cause an effective kissing balloon dilatation. So 3D OCT, after main vessel stenting, we can understand the configuration of the struts over the side branch ostium, and then can guide optimal wire recross and get a good result. So use of imaging guidance to achieve strut-free ostium will be advantageous, particularly in the left main PCI. So thank you. With this, I think I would just want to comment on Dr. Chada's case. I think clearly all these cases were dealing with distal left main bifurcations, and one we need to understand with imaging, and if imaging show we may have to do kissing balloon in all these cases, and make sure we completely remove all the struts away from the ostium, and not only that, make sure we have good apposition and expansion. Thank you.